My name is Emek Kocatürk Göncü. I'm a professor of dermatology and I'm working in Charité University Institute of Allergology. And in our institute, we see a lot of urticaria patients, and urticaria is my favorite disease. Today, I'm in Paris because we are having the EADV Congress here and we are learning a lot about progresses in dermatology. And today, I had the opportunity to talk about urticarial vasculitis. Urticarial vasculitis is the main differential diagnosis of urticaria we see in our clinics. In my talk, I started with talking about the differences between urticaria and urticarial vasculitis. Urticarial vasculitis has some different features than urticaria. It can be presented with ecchymosis or purpura, and the lesions tend to stay longer than 24 hours. They can be burning or sometimes painful rather than having itch. And this is also a distinction of urticaria and urticarial vasculitis. When there is a wheal that is very itchy and stays shorter than 24 hours, of course, then we think about urticaria. But when they persist longer than 24 hours, heal with post-inflammatory hyperpigmentation, leave purpura or ecchymosis, and if the patient has systemic findings, for example, systemic complaints such as arthralgia, arthritis, then we need to be thinking about urticarial vasculitis. And for that, we need to make a punch biopsy from our patients. And in the biopsy, if there is a leukocytoclastic vasculitis, then the diagnosis is urticarial vasculitis. And when we make the diagnosis of urticarial vasculitis, then we need to also differentiate between hypercomplementemic versus normocomplementemic vasculitis. For that, we need to check the complement levels and do some lab workout for our patients. Normocomplementemic urticarial vasculitis is very common. 90% of the urticarial vasculitis patients are normocomplementemic. So this is easy to treat. It can be treated as such urticaria cases. We can use the same treatment algorithm of urticaria we use in chronic spontaneous urticaria patients, normocomplementemic urticarial vasculitis patients. But if there is a hypercomplementemic urticarial vasculitis, then we may need to use immunosuppressive treatment. So the differentiation is very important. Taking the biopsy is very important. Checking the complement levels in our patients is very important. And we need to check for autoimmune disorders and also hematologic malignancies in our patients with urticarial vasculitis. So another topic that I wanted to talk about is our UCARE project, that is risk factors and lifestyle of chronic urticaria patients. So in this project, we collected data from many UCARE centers, more than 50 UCARE centers, and we reached the number 1,500 urticaria patients and also 1,500 control subjects, and we compared if they have the same comorbidities, infection levels, same medications, same vitamins. So we wanted to understand the risk factors that contribute the patients to urticaria, as well as we wanted to understand what they eat, if they are doing sports, if they are living a healthy life. So we will all analyze these findings. One is looking for if some interventions are more common in urticaria patients. What kind of interventions? We checked if they are doing more Botox, more fillers, mesotherapy, dental prosthesis, many kinds of interventions that you can think about or the patients are asking us. Then we found that urticaria patients are doing less cosmetic procedures because I think that is linked to their fear that something can happen. But it is evident that these procedures are not causing or not making their urticaria risk higher. So from that study, we can say that urticaria patients can do these procedures. What was increased? COVID vaccine rates and dental prosthesis was also higher in chronic urticaria patients. But the other things did not differ between urticaria patients and control group. And the second one looked at the comorbidities and infection rates between the control group and urticaria, and we found that our chronic urticaria patients had, before their urticaria started, 3 months before their urticaria started, they had more teeth infection, more urinary infections, and Helicobacter pylori infections, and upper airway infections. Besides that, urticaria patients have more hypertension rates, and also, as we also know from previous studies, they have increased thyroid disease, Hashimoto disease, as we already expect to see. So these are what I want to report from EADV today.